Hello and welcome to Healthcare Voices, where we bring you authentic voices behind healthcare innovation and impact. I'm your host, Catherine Cummings, former clinician turned technology advocate, and today I have the privilege of speaking with Dr. Michael Mintz, a gastroenterologist at Cornell Medicine and assistant professor at Cornell Medicine and New York Presbyterian. Today, Dr. Mintz is going to be discussing his insights into the latest research and technology in GI care, and he's going to be sharing with us his experience working with the next generation of physicians. Thank you so much for joining us on the podcast, Dr. Mintz. It's great to have you here. How are you doing today?
I'm doing great, Catherine. So thank you so much for having me. This is exciting
So,
to
Dr.
speak
Mintz,
with
tell
you.
us a little bit about your background. What inspired you to pursue a career in medicine?
Absolutely. I'm originally from upstate New York. In college, I was actually thought I was going to be a lawyer and was going down the whole political science pathway. Around that same time, a lot of my friends were actually joining EMS. They were doing becoming EMTs and joining the ambulance service. And while I had no interest really at that time, I figured what the heck, I'll just give it a try and join. And it kind of instantly changed my perspective of what I wanted to do with my life, taking care of patients. Being in that exciting environment really changed my interests from law to going into medicine. And I completely changed my major and decided that I wanted to go to medical school, which eventually I did. I went to Stony Brook Medical School on Long Island and then decided to specialize in internal medicine, where I was spun up to Boston at Mass General and Harvard Medical School, and further decided to go into gastroenterology just based off my interests. And yeah, the rest is history.
Awesome. If you could change one aspect about the current healthcare system to better support clinicians, what would it be, and why do you think this change is necessary?
I think the main change that we need is to prioritize putting patients first. So much, unfortunately, of our jobs now is charting on the computer, making sure things are covered by a patient's insurance company, doing all the things that aren't us face to face, sitting with the patient, having a conversation about their disease and illness. And I think that's like the main thing that a lot of like frustrations the physician has. It's all the extra administrative work and the things that take us away from our patients. And I think that um, coming up with a way where we could really get back to taking care of patients and less being slaves to our computer and charting and the other things is extremely important.
I really like that. That's something that I actually spoke to Dr. German about the last podcast. Kind of along that same topic of previous conversations, I'd love to hear about what measures are taken to introduce collaborative care or taking an interprofessional approach in managing GI illnesses. Aside from, the charting and all of those things that need to be done, what kind of clinical communication tools do you use to ensure that seamless communication and collaboration?
I think that's so important, such an important point, Catherine. So much of medicine has become very subspecialized, where we all focus on a little area of care, but it's really so much more complicated than that. And when you work as a team, not just among subspecialty physicians, but also, non-physician members of the team, it really leads to the best outcomes. I'll give you an example. So what I do primarily is inflammatory bowel disease. I'm a gastroenterologist who takes care of patients with Crohn's and ulcerative colitis. These diseases, while primarily gastrointestinal, also have a lot of non-GI kind of systemic manifestations within the patient, whether it be dermatologic manifestations, rheumatology with joint pains, um, increased risk of infectious diseases, malnutrition, psychiatric comorbidities, things like that. So my team, whenever I work with a patient, it involves a psychiatrist, a rheumatologist, a dermatologist, myself, a registered dietitian. It's a huge, as well as all the nurses who work in our office. So it really, me working within my little subspecialty is not really sufficient to take care of that patient anymore. And so, how do we make sure that all members of the patient's care team are working together? I think that really starts with making sure we're all using the same technology platform. It sounds kind of silly, but especially where I work in New York City, patients get their care at so many different healthcare systems, and each system often has its own electronic medical record and way that providers communicate within that system. Um, I often have to, be working with subspecialists at different institutions throughout New York City. And a big challenge of that is that while I'm looking at one medical record, that provider is looking at another medical record, et cetera, et cetera. And we really don't have a common platform that we can all uh, work on together so that we can ensure effective communication. We do have some things that we use. For example, the electronic medical record that most practices use in the city is Epic, where we have a feature that they call Care Everywhere, where I can see some of a patient's charts in other institutions. But I think we need to do a better job of making sure that we're all using a technology platform where we can most effectively communicate. And I think that's really challenging right now.
Interoperability is something that we talk about frequently in healthcare, and I think especially with the patients that go to multiple facilities, go to multiple specialties, and the GI care, for example, that you do that requires them to see multiple specialties in order to appropriately diagnose and care for that patient. If we don't have those things in place, it makes it really challenging to perform care, diagnostic tests, other things like that are imperative to getting that patient well, or at least getting them stable, right, to manage their chronic illness. As far as some other emerging trends or innovations that you're seeing in your field, what are you particularly excited about? What are the things that you're seeing aside from interoperability or that clinical communication that make you excited about the future?
Yeah, there's so many exciting trends happening right now that are in their infancy, but I think in the next 5, 10 years are really gonna kind of take over and enhance kind of the way we do things. I think one of the big area everyone's always talking about is artificial intelligence, AI, and how that will interact with medicine. There's always talk amongst providers that is AI ever going to replace the physician? Um, I think that's answer is no. I think what if we do it right, what we could do is use AI to kind of enhance the physician's abilities. And let me give you an example. Very frequently, in gastroenterology, a big thing we do is screening colonoscopies, where we're looking for little precancerous growths called polyps, and remove them before they have the opportunity to turn into a colon cancer. Colonoscopy is a very operator dependent test where the person holding the colonoscope, you're really depending on them to find these tiny little polyps, and sometimes it can actually be quite difficult. So what a lot of companies right now are looking at is can we build AI into the colonoscopy system there, where if the AI intelligence identifies an abnormality in the colon, it'll put like a little red box around it or highlight it so that it can draw the physician's eyes to that area of abnormality. I think while we do a great job uh, identifying these abnormalities as the physicians, I think we can always be better. And using that technology to be even better, I think will be really important. We can also use the technology I was talking about a little earlier, physicians trying to get as much face time with the patient as possible and less time charting and staring at the computer and clicking boxes. We are working on a lot of technology platforms where, the electronic medical record itself or the um, system can work as like a virtual scribe where it could, listen to what's going on in the either the procedure room or in the care room and start, writing the procedure report for me or writing the clinic note for me so that I know I can have more time to talk to the patient. So I think that's a really exciting aspect of new technology. I think the other thing you're going to see a lot more of is something called wearable technology where we can monitor a patient. You're already seeing it a lot, I think, in the field of cardiology with Apple Watches being able to detect heart rates, abnormalities, and like kind of uh, predict well what's going on with the patient. I think we are trying really hard to create technology where a patient could have some sort of like low profile, device that they wear, whether it be like a little watch, a Fitbit, or they have these rings that can monitor kind of your vital signs and really predict ahead of time when a, pre-existing disease or condition is going to get worse. Some examples are, in the realm of inflammatory bowel disease, can we find a technology that can predict disease flares for Crohn's disease or ulcerative colitis? Like, can we know a month ahead of time before the disease flares, before the patient gets sick, based off variability in their heart rates or things along those lines? Can we make that prediction so that we could change treatment and prevent flares? I think those are some of the other really exciting avenues. The last thing I would say is point of care testing. I think that's so important in healthcare. And the reason why is, I see a patient in my office and I recommend various different tests. Often those tests can't be scheduled for that day, and I don't know if the patient's going to be able to, follow up and actually get that testing done. Uh, as an example, we're starting to institute point of care ultrasound testing in the clinic with the patient so that I can immediately, and use that technology to get a diagnosis as opposed to sending that patient for like an MRI or another test that might take weeks or months to get done. So those are some of the three kind of big areas that I think are big right now: AI, point of care testing, as well as wearable devices. Those are the areas that excite me right now.
That's really cool to hear. As far as the AI goes, I've been hearing a lot more, especially in the remote patient monitoring space, about that ambient technology. Not actually being able to see a video feed of the patient, but being able to see cues within the care environment to either document things or see what the patient might be doing and ensure safety is being measured, things like that. So that's definitely an area of interest for me as well. So it's cool to see that they're looking at doing that for charting as well. And then with the wearables and the point of care testing, I think that's super interesting, especially that point of care testing. There's so many limitations with the wearable technology that we can have now, and so many limitations to the type of technology at the actual, not bedside, but clinic side, maybe in the clinical environment where, like you said, it's so hard to get patients to even come back for a follow-up visit. And if patients are not feeling like they can even go in for the additional testing that's needed, then they might be going undiagnosed for an extended period of time and not be getting appropriately treated. So as far as like the implementing those types of technologies, have there been any unexpected challenges or limitations, especially in that point of care testing that you've seen, and how have you addressed them in your clinic?
Yeah, I mean, that's a great question. With everything, the limitation of technology is to get somebody to pay for it. And that is something that we have to, get approved by, the institution. I work in a large healthcare system. For me to get a piece of technology approved and paid for by my institution, for example, I have to, show the institution that one, this is going to improve patient care, and number two, I have to show that, this technology will actually save the institution money and pay for itself. Um, as an example, if I wanted to make a change and get a new piece of technology, for example, if I wanted to get AI um, on my in my colonoscopies that can point out more abnormalities in the colon, I would have to do like a quality improvement project. That would show that, these physicians, we found X number of more polyps in these patients and therefore improved patient care. That's the kind of data that institutions are looking for in order to provide financial backing. And then, in addition to all the great things it does for the patients, if I'm finding more polyps, then that patient's going to need to come back sooner for their next colonoscopy. So, in the long term, this is actually improving the revenue of the healthcare system and saving lives. So I think if we can see it as a win-win-win for myself, the patient, and the institution who ultimately has to pay for this very expensive technology and equipment, then we can use that to advance patient care and the goals of everybody.
So kind of along the same lines of that, access to care is a topic of conversation that comes up a lot. And you mentioned it a little bit as, how are we doing those point of care testing to ensure that access of care is granted? But what about marginalized communities and communities that might not have the same wealth of health literacy that you or I might have? How are you addressing some of the barriers of not only coming in to see you, right, but also the barriers that they might have with wanting to do additional testing because of the cost? And how are you addressing those?
Yeah, a very important issue and something in New York City we see very frequently. I primarily practice on the Upper East Side of Manhattan, which is a very wealthy, affluent area, but the areas where a lot of the healthcare is most needed is the outer boroughs like the Bronx, Queens, and Brooklyn. So there's a couple of different ways I think we need to focus on. I think um, virtual healthcare is extremely important. Video visits, we have to ensue us ensure that the patients have the technology where they can see us remotely. But I think that's really helpful that, very often the patients don't want to take a day off of work, or they just don't have the time or the resources to make it into my office. So many challenges people face. So if I could see that patient, virtually, and either it be over the phone or through like a video platform, I think that could really help to enrich outreach to these patients, as well as ensure that we have better follow-up. Nobody, wants to come all the way to the doctor's office, take a day off of work for a routine follow-up. So if we can do that over a video platform, that would be great. The second thing is, I would say, outreach. I think major academic institutions with subspecialized care really need to uh, prioritize their physicians going out into the community and doing clinics where we can meet the patients where they live. That's a lot easier said than done, but I think it really needs to be a priority. Something I'm doing starting in a couple months is one day a week taking my clinic out to Brooklyn, where there is less subspecialties, IBD care, inflammatory bowel disease care, to see these patients, and for me to go to them, so that we kind of take down that barrier and access to care. Um, I think that's kind of the most important thing. There's other obvious aspects that we need to do a better job of communicating to patients in language that they speak. I think is also very important and often overlooked. We send patients instructions like how to prep for their colonoscopy, how to get their MRI done, for example, and we need to make sure it's in the language that the patient speaks. We're starting to do a much better job than that, but that was always an issue as well. So I think really putting in the effort and getting buy-in from the academic institutions, that going out into the community, and not just staying uh, where in our offices, on the Upper East Side of Manhattan it's a priority, and that way we can expand our patient base as well, and get these patients access to clinical trials, research, things like that that traditionally are only done in an academic institution. We need to go to them. I think it's really important.
I love to hear that you're doing that. That's really cool. Another thing that I know that you do is you're an assistant professor. I'd love to hear a little bit more about some of your experience working with medical students, with residents, with the next generation, if you will, of physicians coming up.
Yeah, it's very exciting because it's, not that long ago that I was in that position and really looked up and was eager to learn from, all the attendings and all the, mentors I got. I think something that's excites me and I really enjoy is mentorship. I think mentorship is extremely important in any field or whatever you do, not just medicine, but particularly medicine where people, students are looking for a role model and somebody who's done it to kind of take them under their wing and make sure they're doing all the things they need to do in order to become the best, ultimate physician they are. So we really focus on developing mentorship programs with medical students and residents who are interested in going into gastroenterology. I think is really important. Um, Also, really kind of adapting to changes in the way students learn, I think is really important as well. When I'm going to age myself a little here, but when I was in medical school, we were very focusedly on studying from textbooks and, taking notes from PowerPoint slides and lectures. And I think that was the way that medical education was done. I think in the last, I think, couple of years, it's really changed. So much of medical education is done with technology now, and medical education videos online and using like tablets and all these different devices in order to kind of enhance the learning experience. So knowing how students today learn best, I think is really important. And I don't think anymore it's from reading textbooks. I think it's from changing to everyone's becoming, I feel, much more visual learners with videos um, and things like that. It's just different. I think we need to adapt as educators to meet this new kind of age of medical students.
I know that you have some special interests in your research. I'd love to hear a little bit more about that. I know it's an exciting thing for you. So let's hear a little bit more about your special interest in the research that you do.
Yeah, research is a huge part of advancing our field, and I think it's a really exciting time for research. Specifically, what I do with inflammatory bowel disease is drug trials, therapy trials. We are so excited that we now have all these new drugs, medication therapies in the pipeline for treating inflammatory bowel disease. Even when I started my fellowship 3 years ago, uh, we had several options, like three. Now we have 8 to 10 options with more and more therapies coming out each day. So what we have to figure out is with the blessing of so many therapies, it creates the challenge of, you know, personalizing care. And now that we have an option of, where I see a patient, I had 10 different options of medications to start them on. Picking the right medication for the right patient is something that really interests me. And so by, both prospectively and retrospectively looking at inflammatory bowel disease patients and see which drug is best for which specific type patient, I think is really interesting to me, so that we can choose the right drug for the right patient the first time and not need to cycle through multiple medications in order to find that right drug that can get that patient in remission. We have so many therapy trials going on, both phase 2 and phase 3 randomized controlled trials, looking at new therapies for our patients using unique drug mechanisms. And our hope is that we can, come up with new therapies that really can tackle this disease. We've come a long way just in the last 5 to 10 years. A disease that was previously, 15 years was only treatable with steroids and surgery, which led to huge morbidity for patients. Now it's a disease where, we can really almost reach like functional cures for these patients, where we want them to live their lives and not have to think about their disease at all. So that's what has me excited, and that's what I do in the clinic every day. Every time I see a patient, I think, can this patient, would they be a good fit for this clinical trial? So that we could both improve that individual patient's care and for our greater good and greater knowledge, so that we can get more therapies approved into patients.
And my last question, this is a question I like to end the podcast with. What's one thing that you wish people knew about practicing medicine, or just one bit of knowledge that you'd like to impart on our listeners?
Yeah, that's also a great question, and I'm going to change it up a little. And it's like I'm going to say one thing I think the patients to know. It's so important as a patient to advocate for yourself. I think that's really important. We physicians work in, a lot of us, really large health systems with a lot of patients, a lot of bureaucracy, and if we don't hear from a patient advocating for himself, I just assume the patient's doing fine and doesn't need anything. When I don't hear from patients, I assume everything is great. You as a patient are your own greatest advocate. If you're not feeling like you're getting the care you need, or you're not feeling well, or you see something wrong, reach out to the physician's office. Say you want to speak to the doctor directly, and really let us know how you're doing. I think that's extremely important, because again, if I don't hear from you and you're not advocating yourself, we have a lot of patients, and my assumption is that the ones I don't hear from are doing really well. So to summarize, just advocate for yourself, patients. We want to hear from you.
Awesome. Well, that's a perfect way, I think, to end the podcast. I really appreciate your time today, and looking forward to more conversations in the future.
Thank you so much, Catherine. It was great seeing you and speaking with you.
Thank you to all of our listeners for joining us on the podcast today. We appreciate your support. To hear more healthcare voices like Dr. Mintz, hit the subscribe button and share this podcast with your friends and family. I'm your host, Catherine Cummings, and you just listened to Healthcare Voices.